This is Chapter 11, Disorders of Sex and Gender. So experts recognize two general categories of sexual disorders. Those are sexual dysfunctions and paraphilic disorders. Sexual dysfunctions are problems with sexual responses, and paraphilic disorders are repeated and intense sexual urges and fantasies in response to socially inappropriate objects or situations. There's also a category in the DSM called gender dysphoria. It's very controversial. We'll talk about it later in this presentation. And this is a pattern in which people feel that they have been born to the wrong sex and identify with the other gender. So sexual dysfunctions, again, are disorders in which people cannot respond normally in key areas of sexual functioning. It involves as many as 30% of men and 45% of women in the U.S. who suffer from such a dysfunction during their lives, and they're often interrelated with other dysfunctions. The human sexual response has a cycle with 4 phases. Those are desire, excitement, orgasm, and resolution, and typically dysfunction happens within the first 3 phases, desire, excitement, or orgasm. So this is what the normal sexual response looks like for men and women. You can see that it is different in the orgasm phase. For women, there is the possibility of multiple orgasm and also the possibility of resolution without orgasm. So those are the key differences between these 2 phases for men and women. So some people struggle with sexual dysfunction their whole lives, and for others, normal sexual functioning precedes a disorder. And in some cases, the dysfunction is present during all sexual situations. In others, it's tied to particular situations. We'll look first at disorders of desire. The desire phase of the sexual response cycle consists of an interest in or urge to have sex, sexual fantasies, and sexual attraction to others. 2 dysfunctions affect this phase: male hypoactive sexual disorder or female sexual interest disorder. So the clinical criteria for male hypoactive sexual desire disorder follow. For at least 6 months, the individual repeatedly experiences few or no sexual thoughts, fantasies, or desires, and the individual experiences significant distress about this. For female sexual interest arousal disorder, the criteria follow. For at least 6 months, the individual usually displays reduced or no sexual interest in arousal, which is characterized by the reduction or the absence of at least 3 of the following: sexual interest, sexual thoughts or fantasies, sexual initiation or receptiveness, excitement or pleasure during sex, responsiveness to sexual cues, genital or non-genital sensations during sex, and again, the individual experiences significant distress as a result. Most cases of low sexual desire or sexual aversion are caused primarily by sociocultural and psychological factors, but biological conditions can also lower sex drive. So biological causes can be hormone abnormalities, such as with prolactin, testosterone, and estrogen for both men and women, and they can also be the result of medications, drugs, and chronic illness. Psychological causes can include general increases in anxiety, which is a huge factor for many disorders of sex, and also depression or anger. Fears, attitudes, and memories can contribute to sexual dysfunction and certain psychological disorders. Sociocultural causes can include attitudes, fears, and psychological disorders, situational pressures, molestation or assault, and cultural standards. So this is a look at what the normal female sexual anatomy looks like during the desire and the orgasm phases. We'll move on now to disorders of excitement. The excitement phase of the sexual response cycle is marked by changes in the pelvic region, general physical arousal, and increases in heart rate, muscle tension, blood pressure, and the rate of breathing. For females, female sexual interest and arousal disorder may include dysfunction during the excitement phase. For males, male erectile disorder involves dysfunction in the excitement phase only. And this is a look at what the normal male sexual anatomy looks like during the desire and the orgasm phases. Erectile disorder is characterized by persistent inability to attain or maintain an erection during sexual activity. It occurs in as much as 25% of the general male population, and it's found in half of all adult men who have erectile difficulty during intercourse at least some of the time. The clinical criteria follow. For at least 6 months, the individual usually finds it very difficult to obtain an erection, maintain an erection, and/or achieve past levels of erectile rigidity during sex. and the individual experiences significant distress as a result. Medical procedures, including measurement of nocturnal penile tumescence, or NPT, are typically used for diagnosis of erectile disorder. Men typically have erections during REM sleep, and so abnormal or absent nighttime erections usually indicate a physical basis for erectile failure rather than a psychological one. Some potential causes for erectile disorder: biological causes, vascular or blood vessel problems, nervous system damage, medications, and substance use; psychological, depression, performance anxiety, and the spectator role; and sociocultural stressors, physical intimacy patterns. We'll look now at disorders of orgasm. The orgasm phase of the sexual response cycle is when sexual pleasure peaks and sexual tension is released as the muscles in the pelvic region contract rhythmically. There are 3 disorders of this phase: premature ejaculation, delayed ejaculation, and female orgasmic disorder. The clinical criteria for premature ejaculation follow. For at least 6 months, the individual usually ejaculates within 1 minute of beginning sex with a partner and earlier than he wants to, and the individual experiences significant distress as a result. The clinical criteria for delayed ejaculation: for at least 6 months, individual usually displays a significant delay in frequency or absence of ejaculation during sexual activity with a partner, and again, the individual experiences significant distress. And finally, for female orgasmic disorder, the clinical criteria are: for at least 6 months, the individual usually displays a significant delay in frequency or absence of orgasm, and/or is unable to achieve past orgasmic intensity. And as always, the individual experiences significant distress as a result. So again, premature ejaculation is characterized by persistent reaching of orgasm and ejaculation within 1 minute of beginning sexual activity with a partner. Psychological causes are believed to be due to sexual inexperience, anxiety, hurried masturbation, and poor sexual arousal awareness. Biological causes are believed to be genetic predispositions, abnormal serotonin reactivity, and sensitivity nerve conduction around the penis. Delayed ejaculation again is characterized by a repeated inability to ejaculate or by a very delayed ejaculation after normal sexual activity with a partner. Biological causes are believed to be performance anxiety, spectator role, masturbation habits, hypoactive sexual desire disorder. Psychological causes are believed to be low testosterone, neurological disease, head and spinal cord injuries, antidepressants, and medications. And these are actually backwards. So the psychological causes are performance anxiety, spectator role, masturbation habits, hypoactive sexual desire disorder. The biological causes are low testosterone, neurological disease, head and spinal cord injuries, depressants, medications. For female orgasmic disorder, again, this is characterized by persistent failure to reach orgasm, experiencing orgasms of very low intensity, or delay in orgasm. Biological causes are believed to be diabetes, neurological disease, medications, skin sensitivity, or clitoral structural changes. Psychological causes are believed to be depression or childhood trauma. And sociocultural causes are believed to be repression of female sexuality, which is, again, a cultural issue, unusually stressful events, initial experiences with intercourse, attraction, and marital happiness. We'll move on now to disorders of sexual pain, and we'll look at genitopelvic pain penetration disorder. This occurs when enormous physical discomfort happens during intercourse and experienced by women much more often than men. It may involve learned fear responses, relationship difficulties, infection, or disease. The clinical criteria follow. For at least 6 months, the individual repeatedly experiences at least one of the following problems: difficulty having vaginal penetration during intercourse, significant vaginal or pelvic pain when trying to have intercourse or penetration, significant fear that vaginal penetration will cause vaginal or pelvic pain, or significant tensing of the pelvic muscles during vaginal penetration, and the individual experiences significant distress from this. So 2 areas that we look at under genitopelvic pain penetration disorder: vaginismus and dyspareunia. So for vaginismus, muscles around the outer third of the vagina will involuntarily contract, and this will prevent entry of the penis. There's not a lot of research about this, but it's believed that it affects about 1%, potentially less than. and sexual pleasure is still possible. It's believed to be caused by psychological factors or infection, disease, or menopause. For dyspareunia, the experience of severe pelvic or vaginal pain occurs during sex, and it's believed that slightly over 14% are affected. This is typically due to physical causes, often injury, so childbirth or intercourse, and sometimes from infection or pubic hair, tumors, cysts, or allergic reactions. So we'll move now towards looking at treatment of sexual dysfunctions and sexual disorders. And the perspective has changed quite a bit over the last several decades. So you can see that a little bit. So we'll look at kind of general ways of treating and then the kind of current trend. So the general features of sex therapy are to assess and conceptualize the problem, to establish mutual responsibility between partners, to educate about sexuality, to assist with emotion identification, to help with attitude change, to eliminate performance anxiety and the spectator role, to increase sexual and general communication skills, to change destructive lifestyles and marital interactions, and to address physical and medical factors. So there are some specific techniques that are used for specific disorders, and we'll look at some of those now. For disorders of desire, these are very difficult to treat because many of the issues that feed into them are from different perspectives, again, biological, psychological, sociocultural, so there are a lot of different things that can impact these. Therapists typically apply a combination of techniques since there are such varied potential causes. So effectual awareness is one technique, and this is using visualization of sexual scenes to identify negative emotions that may surround them. Self-instruction training, which is replacement of negative thoughts with positive coping. This is especially helpful for people who experience spectator role. Behavioral approaches, which are aimed at increasing desire and or addressing past trauma. And biological interventions, including hormone and therapy and medication. For erectile disorder, treatments typically focus on reducing performance anxiety or the spectator role, and increasing stimulation. So many can include sensate focus exercises such as the tease technique that's described in your text. Biological approaches typically use medication, so drug therapy, and the most popular of those is Viagra. For premature ejaculation, behavioral procedures are largely used, and those include the stop, start, or pause procedure, which is similar to the tease technique. Biological approaches can include antidepressants, such as SSRIs. For delayed ejaculation, behavioral procedures are most common. These include reducing anxiety, and then biological approaches, medication when there are physical factors that are believed to be the cause. For female orgasmic disorder, cognitive behavioral techniques are often used, and so these can include self-exploration, enhancement of body awareness, and directed masturbation. Biological treatments can include hormone therapy and medication, though the latter is not very well supported through research. For genital pelvic pain and penetration disorder, biological approaches are often used because this disorder is typically the result of a physical origin, and so this may include strengthening vaginal muscles or control of vaginal muscles. Behavioral approaches can also be used, including exposure treatment to address any fear and pain management. And then medical interventions sometimes include Botox, though this is not very well supported as well through research, or topical creams and surgery. So there's a little section in your text to take time to look at it, discussing the controversy over how readily available Viagra is compared to contraception. So take some time to look at that and see what you think about it. So current trends in sex therapy have moved away from the Masters and Johnson approach that's described in your text. More attention is paid to persistent sexuality disorder, hypersexuality, or sexual addiction. The use of medications to treat sexual dysfunction are largely not accepted. We'll move on to paraphilic disorders now. The clinical criteria for paraphilic disorders follow. For at least 6 months, the individual experiences recurrent and intense sexually arousing fantasies, urges, or behaviors involving objects or situations outside the usual sexual norms. Non-human objects, non-genital body parts, the suffering or humiliation of oneself or one's partner, or children or other non-consenting persons, for example. And then this is different from previous designations for clinical criteria. Typically, that very last criteria is that it creates distress or impairment for the individual. That is a possibility with some paraphilic disorders. With some paraphilic disorders, it's possible that the person doesn't experience significant distress or impairment, but that it creates significant distress or impairment for others. And so keep this in mind. This will be one of 2 times that you'll see this throughout the entire semester under paraphilic disorders, and also when we get to personality disorders, there are some there as well, okay? So again, paraphilic disorder, a diagnosis is applied only when the urges, fantasies, or behaviors cause significant distress or impairment, or when the satisfaction of those behaviors, urges, fantasies creates risk or of harm to someone else, currently or in the past. There are various theoretical explanations for paraphilic disorders, but there's little formal supporting evidence for any. Treatments can include psychological and sociocultural. Those are the ones that have been available the longest. Contemporary professionals can also use biological interventions. Those often involve some type of hormone therapy, so anti-androgens, which will lower testosterone, which will reduce sex drive, or SSRIs, again, which are antidepressants, but the hope is that they will have the impact of reducing compulsion-like sexual behaviors. We'll look at fetishistic disorder now. This includes recurrent intense sexual urges, sexually arousing fantasies, or behaviors involving the use of a non-living object or non-genital part, often to the exclusion of all other stimuli, and accompanied by clinically significant distress or impairment. Research can identify causes, but behaviorists think that classical conditioning may be at the root. Treatment often includes aversion therapy, covert sensitization, masturbatory satiation, and orgasmic reorientation. Transvestic disorder, which is referred to usually socially as cross-dressing, is characterized by fantasies, urges, or behaviors involving dressing in the clothes of the opposite sex in order to achieve sexual arousal. It may involve operant conditioning, and it's often confused with gender dysphoria that we'll discuss later in the chapter. Exhibitionistic disorder is characterized by arousal from the exposure of genitals in a public setting. Treatment usually includes aversion therapy as well and masturbatory satiation, and it may be combined with orgasmic reorientation, social skills training, or cognitive behavioral therapy. Voyeuristic disorder is characterized by repeated and intense sexual urges to observe people as they undress or engage in sexual activity. Under the psychodynamic perspective, the cause is believed to be power seeking. Under the behavioral perspective, the cause is believed to be learned behaviors. Frotteuristic disorder includes repeated and intense fantasies, urges, or behaviors involving touching and rubbing against a non-consenting person. This is something that can happen fairly commonly in large cities and crowded spaces. It usually begins in the teen years or earlier. Pedophilic disorder is characterized by repeated and intense sexual urges or fantasies about watching, touching, or engaging in sexual acts with children. The person either acts on these urges or they experience clinically significant distress or impairment because of the urges. There are 3 different types. The classic type is attraction to prepubescent children. The hebephilic type is attraction to early pubescent children. And the pedohebephilic type is both pubescent and early pubescent attraction. Causes are not completely known, but there are traits that have been established among people who experience this disorder. So the pattern typically develops during adolescence, and there is sometimes a pattern of childhood sexual or other abuse and neglect. Often there is the presence of sexual difficulties and life problems that threaten dominance. There's often immature social and sexual skills, the presence of another psychological disorder, and there's also some indication that there may be potential biochemical or brain structure abnormalities for people with this disorder. Not a lot of research support for the latter so far. Treatments, the number 1 treatment, which is not actually a treatment, is prison. And this, of course, is it means to keep people safe. But oftentimes there will be sex offender treatment sessions or facilities within prisons. And so sometimes those will have treatments that are similar to those for other paraphilic disorders. and often relapse prevention training is a part of the strategy as well, so where they are trained to identify the triggers around the inappropriate behaviors and to create avoidance strategies. Sexual masochism disorder is characterized by fantasies, urges, or behaviors involving the act or the thought of being humiliated, beaten, bound, or otherwise made to suffer. Most fantasies begin in childhood. The cause seems to be through the development of classical conditioning, so associating these urges with something else. Sexual sadism disorder is characterized by repeated and intense arousal by the physical or psychological suffering of another individual. This occurs more for men than for women. It may first appear in childhood, but it's usually progressive, and classical conditioning or modeling is believed to be a cause. Also, strong elements of desire for power and control, feelings of sexual inadequacy, and there may also be the possibility of brain and hormonal abnormalities for this disorder as well. Treatment usually involves aversion therapy and relapse prevention training. So the definitions of many of these paraphilic disorders are strongly influenced by the norms of the particular society in which they occur. So, for example, with the exception of those that create harm for other people, for children, the disorders may not be considered disorders in other countries where attitudes towards sex are different, okay? So for this reason, some clinicians argue that these behaviors should be considered disorders only when they are harmful to the individual or other people around them. So we'll look last at gender dysphoria, and again, this is the category that's been added to the DSM that I mentioned at the beginning of this presentation that has been very controversial. So people with this disorder persistently feel that they have been born to the wrong biological sex and gender changes would be desirable. We typically refer to these people as transgender socially. Gender dysphoria is more than a variant lifestyle and is not a clearly defined medical problem. And as such, that's why it is seen as very controversial. So some people say that it's more of a lifestyle choice and that it shouldn't be categorized as a disorder. This is the criteria for the disorder, however. For 6 months or more, individuals' gender-related feelings and or behaviors are at odds with those of his or her assigned gender, as indicated by 2 or more of the following symptoms. Gender-related feelings and or behaviors clearly contradict the individual's primary or secondary sex characteristics. There's a powerful wish to eliminate one's sex characteristics, a yearning for the sex characteristics of another gender, a powerful wish to be a member of another gender, a yearning to be treated as a member of another gender, and a firm belief that one's feelings and reactions are those that characterize another gender, and the individual experiences significant distress or impairment. And so, that second criteria that is often a part of these disorders, that is usually a part of these disorders, that the individual experiences significant distress or impairment, this and some biological evidence are kind of the driving force behind this being categorized as a disorder rather than being categorized as an alternative lifestyle. So as I said, it is definitely controversial as a disorder categorization. Many people believe that transgender experiences reflect alternative, not pathological, ways of experiencing one's gender identity, and others argue that gender dysphoria is a medical problem that may produce personal unhappiness. So take some time to think about what you think, because there is compelling evidence for both sides. So again, the characteristics are a desire to change primary and secondary sex characteristics and acquire the characteristics of the other sex. Biological explanations, there's been a lot of interesting research here lately. So those with the disorder had heightened blood flow in the insula and reduced blood flow in the anterior cingulate cortex. This is an area of the brain. And these brain areas are known to play roles in human sexuality and consciousness. There's also a cluster of cells in the hypothalamus called the bed nucleus of stria terminalis. This is BST. And they're only half as large in people with the disorder as in people who do not have the disorder. Also, a woman's BST is much smaller than a man's. So what they found in research is that the male-assigned people with gender dysphoria, meaning transgender men, were found to have a female-sized BST. It may be that male-assigned people who develop gender dysphoria have a key biological difference that leaves them very uncomfortable with their assigned sex characteristics. There's also some indication that this may run in families, again hinting towards that genetic biological predisposition. What's odd about this is that when we look at sexual orientation, which you may remember studying in introductory psychology, similar biological evidence has pointed the field towards an assertion that sexual orientation is not a disorder and is largely the result of genetics. And so because we see this strong genetic implication for gender dysphoria, it's a little interesting or odd that they have taken a different position and said that this is in fact a disorder. So the key here may rest upon, again, that piece of impairment and distress for the individual. There are three different patterns of gender dysphoria: female to male, male to female, and male to female again, so androphilic type and autogynophilic type. And so these just have to do with the direction to which the desire for different gender is oriented, and also for the final pattern, there is not actually an attraction, but just a desire to be seen, so that the attraction comes from the idea of being seen as the opposite sex, not to the actual opposite sex. Okay. Treatments include psychotherapy, biological interventions, can include hormone treatment, surgery. The most common, and that you're likely more familiar with, is sexual reassignment or sex change surgery. All right, that concludes this chapter. Hopefully you've already gotten in and started the learning curves. They're due Friday. The test is due Sunday. And remember that next week is spring break, so I hope that you have great plans, and I hope that they are safe and fun. I look forward to seeing you guys after spring break.